Okay. Hello, everyone. Very good evening to all of you. I am Dr. Sonali Agrawal, IFS Executive Member of MP Chapter. I welcome you all in this 8th webinar of Polaris series. This is the monthly unique webinar on imaging in gynecology and infertility. For that, I am really grateful to our dedicated leader, Dr. Bela Bhatt Madam and Dr. Priya Bhave Chittawar Madam for giving me and showing their trust and confidence in me. I am really honored to invite our dynamic, enthusiastic leader, Dr. Bela Bhatt Madam. She is a MS and FICOG. She is the chairperson of Foxy Imaging Science Committee since 2021 to 2024. She's a lead consultant at Dr. Bela's Women's Hospital and Fetal Medicine Center, Andheri, Mumbai. She's a fetal medicine consultant, Dr. Baba Saheb Ambedkar Memorial Central Railway Hospital, Mumbai. She's FMF UK certified sonologist for fetal abnormalities and nuchal translucency scans. She's a Foxy certified trainer for ultrasound in obstetric and gynecology. She's the author of book The Vital Skills Ultrasound in Obstetric and Gynecology. She's joint secretary of Association of Fellow Gynecologists, Mumbai. She's managing council member of ISPAT and she's life member of SFM. She has received many awards and she has won the PCP entity case in Mumbai High Court by fighting
Thank you so
it
much.
in personal. I welcome you, ma'am.
Thank you so much, Sonali, for those kind words. Well, at the outset, I would like to extend a warm welcome as the chairperson, Foxy Imaging Science Committee, and I'm extremely happy to join hands with IFS MP chapter and the two strong pillars of IFS, Dr. Sonali Agrawal and Dr. Priya Bhave. And as Dr. Sonali mentioned, this is the 8th webinar in this series.
Right.
And in this series, what we try to do is we have tried to please stop sharing so that I can see everybody. Yeah. So in this series, we have tried to address topics like imaging in infertility and gynec, because that is something which has not been addressed much, and there's a lot to learn in day-to-day practice. If we use these, then it'll be really very beneficial to the patients as well as the gynecologist. And for that, we every time we select very eminent and knowledgeable speakers. And today also we have none other than Dr. Madhavi Nori from Hyderabad, who's going to speak on how to diagnose the pelvic and endometriosis, and with the help of ultrasound, which is a non-invasive tool. For years, we have learned that, endometriosis we can diagnose only on a laparoscopy, and we can do the staging only on the laparoscopy, etc. But this non-invasive tool, that is ultrasound, has come a long way, and that's the reason why we need to master this skill, and we'll do the same with the help of Dr. Madhvi Nori. Well, I'm extremely thankful to the President Foxy, Dr. Jaideep Tang, Secretary General, Dr. Madhvi Patel, and my VP in charge of Foxy, Dr. Girija Wagh, for always supporting all the academic activities of Imaging Science Committee, Foxy. Today, we are very fortunate because we have the chief guest, none other than Dr. Shyam Desai, and guest of honor, Dr. Bhaskar Pal. So we would like to have their blessings. Dr. Sonali, can we have the CVs of our
Sure.
chief guest and guest of honor? So Dr. Shyam Desai doesn't need any introduction, but we all know that he has been the past president of our own Foxy. He is currently the president of CEFOG from 23 to 25, past president Mumbai OG Society, past president Indian Association of Gynec Endoscopists from 2003 to 2005, chairman Maternal and Perinatal Health Committee EOFOG from 2009 to 2013, and chairman Board of Trustees Mumbai OBGYN Society for 7 years till May 2023. He has been a teacher in Mumbai University for 30 years, an honorary professor at Wadia Hospital for 25 years, consultant Port Trust Hospital, and is currently obstetrician gynecologist, endoscopic surgeon at Induja Hospital and Nanavati Hospital, Mumbai. Sir has always been very, very supportive and a very, very keen academician. And today we would like to start this webinar with the blessings of Dr. Shyam Desai. Over to you, sir.
Thank you, Bela, for the kind introduction. I'm extremely happy to be invited as a chief guest for this webinar. You have been doing a lot of good work for the FOXY Imaging Science Committee. Keep it up, and I'm sure it'll reap benefits in the future. In the SAFOG region, there are many people who are keen on learning newer techniques and newer technology. And I'm sure at some particular time, if you are able to reach out to the SAFOG countries, you'll be able to attract more audiences for your webinars. So we'll try and help you to try and spread your wings a little bit. Now, the topic for the day has been chosen well. Endometriosis is a problem that is now fairly common, and it is not unusual to have even young girls in the adolescent age who come with severe dysmenorrhea. We treat it mainly as primary dysmenorrhea, but sometimes there can be a endometriotic overlay or the endometriotic base or the dysmenorrhea. And therefore, it is important to diagnose properly so that we treat them properly. The excellent drugs that are available now, mainly the progestins, and we can give them symptomatic relief as well as prevent the presence or the development or progress of the disease. At one time, you are right, as you said, that the diagnosis of endometriosis was made laparoscopically, but with non-invasive techniques coming in, it is important to pick up these endometriotic early nodules and cysts so that we are able to diagnose and treat them properly. MRI is supposed to be superior in picking up these smaller nodules, and therefore, besides the ultrasound, we might have to subject the patient to an MRI as well. Now, bladder endometriosis, bowel endometriosis, and ureteric endometriosis, and deep infiltrating endometriosis can be picked up very well with these imaging techniques. I wish the webinar all the very best, and I'm sure you'll have a good discussion so that we are able to, the audience is able to get a lot of information from this webinar. Thank you so much, Bela.
Thank you so much, Dr. Shyam Desai, for spending your time and giving your pulse of wisdom. Thank you so much. Yeah, can we have the CV of Dr. Bhaskar Pal, sir?
Sure.
So we would like to welcome Dr. Bhaskar Pal. Again, we all know Dr. Bhaskar Pal very well. He's the President-elect FOXY 2026. Sir is Senior Consultant and Gynecologist at Apollo Multispeciality Hospital, Kolkata, Chair Endoscopy Committee, SAFOG, Chair AICC-RCOG 2021 and 2023, President IH 2022 to 23, FOXY representative.
That should be okay. That should be okay, Bella. That's fine. Thank you very much.
We all know you, and we are all
thank you. Thank you.
Have your pulse of
Thank you.
blessings.
Yeah,
Yes.
at the outset, I want to thank FOXY as well as IFS. In general and in particular, Dr. Bela Bhatt and Dr. Sonali Agarwal for inviting me to be the guest of honor. And I think it's a wonderful format that you give. You have one topic and you give a lot of importance to that and to discuss it threadbare. Whenever we talk of endometriosis, we keep on saying that laparoscopy is the gold standard for diagnosis of endometriosis. When we speak these days, we say that, and when I say that, and I say that hopefully it will be soon that we won't come back and say that this is the gold standard for diagnosis of endometriosis, because we are waiting for a day when radiology would take over. And if you look at the issue is that there is a lack of training. I think the number of people who can diagnose endometriosis and even assess the severity of endometriosis properly is limited in India. And a lot of people are not aware that it could be done. And a lot of people are not aware that it could be done. But if you go back and look at the IDEA papers, and they have shown that not only that it has got a very good sensitivity and specificity, it also compares well in terms of when you compare it with MRI. The problem in India is we see too many MRIs being advised for women with endometriosis when The only indication of MRI is when you're planning a surgery for bowel endometriosis. And that is because that we have a lot of radiologists or sonologists who do not know how to interpret the ultrasound, because what the mind doesn't know, the eyes can't see. And that is why you go back on an MRI hoping that you'll pick up something else. I have never heard Dr. Madhvi, but I have heard very good things about her from one of my old junior colleagues who is Vimi Bindra, and I would give Vimi the credit for bringing Dr. Madhvi onto the gynecology fold. And the current IAG president, when he first heard Dr. Madhvi in Hyderabad, insisted that we get her to speak in one of our IAG conferences. And I think so there's a lot to learn in terms of imaging in endometriosis. And I think the day is not far when we say that laparoscopy is no longer the gold standard for diagnosing endometriosis, and we can rely on radiology. Thank you very much, and thank you again for inviting.
Thank you so much, Dr. Pascal, for your valuable inputs and for blessing us all.
Thank you so much, sir, for coming here and your blessings. So Dr. Priya Bhave madam is not able to join. She's traveling. So, ma'am, we can start our next session.
Yes, let's start with our session. Sonali. Yeah.
So now we are very excited for today's scientific session of this webinar. Topic is diagnostic strategy in pelvic endometriosis. For that, I would like to invite our honorable esteemed chairpersons. First is Dr. Preeti Sharma. She's from Jaipur. She has done, she's a senior consultant, Cocoon Hospital. She's affiliated with Foxy, Jogs, IMS, ISAR, ESOPAP, and she's a past president, Jaipur Obstetric Gynec Society 2022, trainer of Master Trainer Foxy, RAC, and Lakshya and Manita. She's awarded with Foxy Achiever Award, Foxy International Achiever Award, Dhira Award, Achiever Award, CCC, Foxy International Conference. She is expert in high-risk obstetric, infertility,
I
advanced.
think that's enough.
I welcome.
I just want to say I'm from Jaipur. Yes.
Yeah.
Yeah.
Thank you so
much.
Next chairperson is Dr. Abha Jain. She is the director and chief of Lifeline Hospital and IVF Center, Bhopal. She's graduated and postgraduated from Gandhi Medical College. She's practicing since last 37 years and started her own private hospital in 1992. She started Bhopal's first infertility center in 1996, and she's trained in IVF Center, Melbourne, Australia. She started IVF Center in 2010. She attended various national and international conferences. I welcome you, ma'am. So Dr. Leela Vyas, madam, she is unfortunately will join late because of some reason. So I ask our chairpersons to kindly introduce our today's speaker. Over to you, ma'am. Mr. Himanshu, Dr. Madhvi Noori's CV, please. Thank you.
So it's my pleasure to introduce Dr. Madhvi. She's from Hyderabad, and she's director of Madhvi Scan Center, second opinion clinic with focus dedicating imaging for all ultrasound indications. She's a consultant radiologist at Vista Imaging, and she has many publications and chapters in the books in national and international, and she has presented many posters and papers in international conferences. She has received many medals, gold medals and cash prizes in MBBS, in MD, and university first rank in MD. And she has participated as faculty in zonal, state, and national CMEs, and she has mentored more than 20 postgraduate students. So welcome, Dr. Noori Madhvi, and we are eager to listen to your talk.
Thank you so much. I'm extremely privileged and honored to share this august gathering of eminent clinicians. It is the clinicians who taught me the way to look at imaging. So clinical relevant radiology, I owe it to the clinicians I work with. Before I start my presentation, I would just like to tell all these what always what always used to surprise me was all these white-bound journals, whichever published these highest specificity and sensitivity studies, high rate of accuracy. I always used to think why this is lacking in clinical practice. Then I realized all these guidelines are published from the European countries where imaging as a part of the clinical curriculum. Whereas in India, imaging and clinical branches, they are parallel road tracks side to side without common formal method of communication. So that is the challenge. So with this background and this difficult, phenotypically diverse topic of endometriosis, I have made an outline and let us see how it goes. This will be an open platform. Anytime you are open to raise, and then it can be interactive. So the topic was diagnostic strategies in endometriosis. So the outline of this talk or the presentation in the first half, I have made it as background on endometriosis phenotypes and diagnostic discrepancy, revisiting anatomy with better understanding of the disease patterns. This is imaging strategies in endometriosis using the available modalities, that is ultrasound and MRI. Then structured reporting or conveying the findings after a proper protocol study using Enzian classification, then understanding the pitfalls or controversies in endometriosis diagnosis, and then look at the performance of individual modalities and what is the surgical implications of the imaging findings you see. And finally, to suggest a clinical algorithm in practice. To look at the background, as clinicians, you all would be well versed. It is a chronic, recurrent inflammatory condition, estrogen dependent, and it is mainly found in pelvic location with extrapelvic sites of involvement. The incidence is approximately 10% of the patients. It is still diagnosed late and remains undiagnosed in a large subset of population, which results in disease progression and negative impacts on health and well-being. Currently, although imaging has taken a large platform for non-invasive diagnosis, majority gynecologists still rely heavily on laparoscopy for diagnosis, which results in diagnostic delays of 6 to 7 years. And phenotypically, the endometriosis is diverse in its presentation, with ranging from superficial peritoneal endometriosis to endometriomas to deep endometriosis and varying spectrums of adhesions and obliterations. But if you look into the overall performance of the diagnosis to intraoperative findings, there is significant discrepancy between the diagnostic performance and intraoperative findings. Look at this. This is the most common diagnosed entity, that is the chocolate cyst, thick-walled unilocular cyst with ground glass low-level echos. And this is the laparoscopic correlate. It is easier to diagnose, but there are these spectrum which goes undiagnosed and is the difficult part of the surgery. So this is the crux as to how do you understand the entire spectrum of endometriosis. So this has led to the limitations of imaging perceived by clinicians that imaging cannot rule out overall endometriosis. It is still dependent on surgical and histological diagnosis. In absence of surgery, presumptive diagnosis. So this is where it stood. And now to look at why is the discrepancy between diagnostic performance and intraoperative findings, and what can be done to bridge the gap. Now, if you look from an imaging perspective, female pelvis was imaged by a basic pelvic ultrasound as per AIUM guidelines, where you used to look for the uterus, the ovaries, pouch of Douglas for fluid or masses, where you can reliably diagnose ovarian endometriomas, which represent of iceberg, and there ended the job. But intraoperatively, the spectrum was significantly different. Now, how can we bridge the gap? There came ISWOG approved IDEA consensus of deep endometriosis ultrasound. If you look to this consensus, what does this show? It shows apart from the standard genital organ anatomy, what you see on a basic pelvic ultrasound, you go beyond the genital organs, you assess for the mobility, you look for the bowel, you look for the uterosacral ligament, you see the bladder, ureter, vagina, rectovaginal septum, pouch of Douglas for fluid obliteration and nodules. So with this thing, you can not only pick up ovarian endometriomas, you can characterize the extent of the inflammatory distribution of deep endometriosis and pouch of Douglas obliteration reliably. Now, if you relook into this, what exactly does this idea consensus does? It is the same machine, it is the same probe, patient remains the same, anatomy remains the same, but you are going beyond the genital organ anatomy. For this, the first point we should realize is genital organs are not standalone structures in pelvis. They are in close relationship to adjacent compartment structures, and there are certain ligaments and the coverings over the genital organs which are not reliably assessed by imaging as perceived previously. So the trick is to understand the anatomy and acquaintance with normal imaging appearance beyond genital organs, which will allow for a precise reporting. You have to go beyond the routine evaluation with standard planes of section, and all these ligaments, reflections, torus, uterosacral ligaments, they are not a separate identifiable anatomical structure. You have to identify the normal landmarks to identify the ligamentous attachment. That is the crux. And spaces, as the pathological condition affects the ligaments of female genital organs and pelvic spaces, and change their imaging appearance. So this is the crux of understanding pelvic endometriosis imaging, because as clinicians, if you enter into the abdomen through laparoscopy or open surgery, you are targeting or reaching the genital organs from a global point. And the same global imaging in a cross-sectional plane or dynamic assessment can be done on an imaging as long as the surgical or the clinical situation demands. So if you look into the pictorial representation of most common sites involved in pelvic endometriosis, it is transcompartmental, multi-compartmental involvement, anterior, middle, posterior compartment. So what do we understand by this? You have to look into the anatomy not only as genital organs, but female pelvic anatomy should be understood and reported as a compartmental format. Anatomical regions in female pelvis can be divided into anterior compartment structures comprising of the urinary bladder and the urethra. The middle compartment structures, that is the uterus, vagina, ovaries, fallopian tubes, and the parametrium. Posterior compartment structures, the bowel, rectum, and the surrounding connective tissue, rectovaginal septum, uterosacral ligaments, torus, the rectovaginal pouch, and pouch of Douglas. So this forms the first step is go beyond the genital organ anatomy. So you have to understand the anatomy as seen in compartments. Can you see on transabdominal ultrasound? Can you see on transvaginal survey? Or do you see it on MRI? Yes, you can see the anatomy both on a transabdominal scan, full bladder, anterior compartment, middle compartment, posterior compartment, on a transverse view as well as the sagittal view. The same can be seen on MRI. Anterior compartment, middle compartment, posterior compartment. So once you identify the compartmental nature, you can assess it on any imaging modality. You can choose the imaging modality based on the clinical situation or the demand. Now, coming to the internal genital anatomy as seen on a transvaginal scan. Female genital organs are positioned in the central compartment in female pelvis. Now you start your scan from the pelvic floor, introduce the probe, scrutinizing the pliability of the vaginal walls, mobility. Now you place the probe into the fornix, and then you look at the uterus, uterocervical length for its mobility, dynamic sliding assessment, tenderness. Then you move your probe on either side of the uterus on a sagittal to parasagittal aspect. Then you move the orthogonally turn the probe from caudal to cranial aspect, you are aiming to look at the cervix, external os, internal os, uterine corpus, the endometrial cavity, both the cornua, origins of the tubes. Then you trace the tubes on one side. This is the uterovarian ligament, which will lead to the ovary with its definite signature pattern of follicles with stroma. Very clear periovarian plane. Look at the organ, its signature, its relationship to surrounding structures in the pelvic compartment. The same thing can be repeated on the other side, left cornua, left uterovarian ligament, clearly tracing it to the left ovary, which reveals a functional cyst or a corpus luteum cyst. So this is a standard internal genital organ assessment as per AIUM guidelines, where you can very clearly identify any pathological cysts in the ovary. Now, you go beyond the genital organs into anterior compartment, middle compartment, and posterior. We have seen middle compartment structure. Now let us see anterior compartment. Can you see on a transvaginal scan? Yes, and definitely yes. What comprises anterior compartment structure? It is the urinary bladder, urethra, periurethral regions, vesicouterine region, and distal ends of the ureters. Now, this is a schematic representation of anterior compartment anatomy. The vesicouterine pouch is a potential space which is not otherwise seen as an anatomical structure. When you trace the line of the peritoneal reflection over the bladder and over the anterior aspect of the uterus, this is the vesicouterine space on imaging and its laparoscopic correlate. And once you orthogonally turn the probe, the cervix from its external os to internal os, you can image the parametrium. For ureter tracing, you have to place the probe at the uretrovesical junction, orthogonally turn, and then trace the ureter laterally along its pelvic sidewall course, where it bridges under the uterine vessels. So this much of anatomy you can precisely delineate on an imaging, which you can see on a laparoscopic correlate. Coming to posterior compartment as seen on the transperineal views, the normal anatomy, first it starts with the perineal body, the extraperitoneal portion of the rectovaginal septum. This is the anterior aspect of the external sphincter, anal canal, posterior puborectalis sphincter, rectal ampulla, external and internal sphincters, and the puborectalis. This is the posterior compartment transperineal view anatomy. And if you introduce the probe focusing posteriorly, you can look into the extraperitoneal portion of the rectovaginal septum, the deepest pouch of reflection of the peritoneum, and the rectum. And how does the posterior parametrium look like on imaging? Posterior parametrium is nothing but stripe of connective tissue composed of collagen fibers, nerves and vessels, and extracellular matrix oriented in horizontal direction, which traverse from the lateral pelvic wall into the cervix. So this is the laparoscopic correlate. How do you see it on imaging? Now you look, your probe is in the vaginal fornix. You are trying to interrogate this structure. So what should form the anatomical landmark for assessing the parametrium? It is the cervix. Once you place the probe into the cervix, you can define the anatomy of the cervix, anterior lip, posterior lip, external os, internal os. When you trace this hyperechoic line of the peritoneum, this is the clear reflection of pouch of Douglas. And the same anatomical correlate you can replicate on laparoscopic imaging. Now, when I say this is the sagittal view, if I orthogonally turn the probe and then orient and sweep this anatomy from caudal to cranial region, this would be, what would be the first slice which I would be seeing? This is the reflection of the posterior vagina over the cervix. So this is the posterior vaginal fornicial reflection. So any deep endometriotic nodule in the vaginal fornix in the background of clinical significant dyspareunia should alert you to image this space in a high resolution. And is it possible to do it? Yes, very well possible. So orthogonally turn the probe, orient at the external os, then cranially move the probe up to the internal os, what you will find the posterior vaginal reflection, clear, continuous echogenic line. The moment you come to the internal os, you will see the parametrium as uterine vessels crossing on the lateral side of the cervix. And it is at this level that the normal anatomical landmark of uterosacral ligament attachment is noted. So this is the level of torus and uterosacral ligament involvement, where 90% of deep endometriosis involvement happen. So once you establish the clarity of the imaging at this level, the negative predictive value of deep endometriosis at this site is high. So ultimately, what is the crux? Understanding the normal anatomy. Now, coming to lateral parametrium on a transverse sweep, the same thing I told you. I have turned the probe orthogonally. I am moving from caudal to, this is the caudalmost point. This is the reflection of the posterior vagina. And then I am moving my probe cranially. This is the vaginal probe, vaginal reflection. Then I am moving my probe cranially, slowly. You can see this is the parametrium. So parametrium is nothing but stripe of connective tissue, which on ultrasound will be seen as a bright hyperechoic area with clear, sharp margins and tortuous vessels, which on color Doppler interrogation will show color filling. But you look at the clarity of the margin. Once you understand this, you can never ever miss deep endometriosis pickup. So caudocranially, you can image the parametrium from the cervix, external os to internal os. So this is the lateral parametrium assessment on TVS. And how far can you interrogate? If you move the probe angulation to this side, you can trace up till the lateral pelvic wall. The same, if you can move it to the other side, you can trace up till the other pelvic wall. It all is dependent on patient's clinical symptomatology. Now, ultralateral compartment, this is where the role of MRI. We had seen the ultrasound imaging of the torus, the parametrium on a TVS in the previous slide. Now, the strength of MRI is it provides you a global anatomical delineation from pelvic side wall till the midline. So, ultralateral neural involvement, where the most important nerve, sacral plexus and splanchnic nerves in deep endometriosis involvement. To characterize this, definitely role of MRI is there. And the nerves stand out against the clarity of the fat in the pelvic peritoneal. So this is how you look at the lateral parametrium on MRI. The levels of deep endometriotic involvement can be medial to the ureter, between the ureter and the hypogastric nerve, lateral to the hypogastric nerve, lateral to the sciatic nerve. So depending on the clinical symptoms, you will see the imaging distortion at these levels. Now, beyond the anatomical landmarks and compartmental assessment, you need to have an idea about the suspensory ligaments of female genital organs, that from caudal and above, you start with the uterosacral ligament. Uterosacral ligament laparoscopic correlate is the bands of tissues clearly attached at torus midline coursing posterior-superiorly to the coccyx level. And how it is seen on an imaging correlate. So the landmark for uterosacral ligament attachment assessment is the cervix internal os, and you see it as a hypointense on imaging MRI, and an ultrasound, as I showed you, it is seen as a bright hyperechoic area at the level of torus in the posterolateral aspects. So this is the most commonly involved entity in the deep endometriosis, where the chocolate cyst, which is easily diagnosed entity, but look at the deep endometriosis of the uterosacral ligament, to which the ovary is adherent and there is tethering of the adjacent bowel. So this is how uterosacral ligament involvement can be picked up, provided you have the idea of normal anatomy of the imaging anatomy of the suspensory ligaments. Second is the cardinal ligament. It forms the base of the broad ligament. Otherwise, it is not seen as an independent structure, but it is again seen at the level of the cervix from the lateral pelvic wall. It carries the vessels with surrounding connective tissue. So it appears as the hypointense vessels across the bright fat. And the important landmark for this is the ureter's course under this cardinal ligament for its entry into the bladder. So any ureteric involvement, lateral parametrial involvement by deep endometriosis, you have to identify this anatomical structure. Coming to broad ligament is a fold of peritoneum over the uterine fundus. It encompasses fallopian tubes with their blood vessels, round ligament, uterine, and some ovarian blood vessels, lymphatic vessels, and nerves. So how is it seen? Because it's a double fold of peritoneum over the genital organ structure, you can trace it from its conduit structures, that is the origin of fallopian tubes and the utero-ovarian pedicle. So this structure represents the anatomical location and orientation of the broad ligament. Coming to round ligament, it is an anteriorly oriented structure. It is best assessed on axial sections on an MRI. Round ligament abnormalities can be characterized best on MRI because of its axial and anterior orientation of the course, and it is fairly difficult to pick up on ultrasound except at its insertion. So this is how round ligament traverses from anterolaterally to the labia. Suspensory ligaments of the ovary, can they be identified? Yes, they can be identified as vascular conduits from the lateral pelvic wall to the ovarian attachment. So these are useful in identifying whenever there is an organ of origin confusion, like the cyst is originating, whether it is a genital organ origin or an extragenital extragyneic pathology in the pelvis. There, the identifying crux is to pick up the draining vessels. It is at that time, or sometimes in torsion, these infundibulopelvic ligaments are crucial to be identified. So this is the infundibulopelvic ligament of the ovary. So you have understood the suspensory ligaments of the genital organs. You have looked at the genital organ anatomy per se as seen on TVS. You have seen its relationship to adjacent compartmental structures. So to sum up, compartmental anatomy of female pelvic and pelvic spaces, intraperitoneum, it is the uterine corpus, adnexa, small intestine, sigmoid colon, upper rectum, extraperitoneum, it is the pelvic spaces. Then you have prevesical space, vesicocervical. These are all anatomical spaces important from a surgical point of view. And urinary bladder, cervix, vagina, and lower part of the rectum are located extraperitoneal. So you look into a single slice of an imaging anatomy, you can characterize how beautifully the genital organ structures are in such a close relationship to other compartment structures, and how the clinical complaints can guide you to triage or strategize the imaging assessment. So reporting checklist when evaluating a female pelvis should not stop at female genital organs. It should include the ligaments of female genital organs and compartmental anatomy of female pelvic and spaces. So this is the crux. And now I'm sure majority of you must be convinced that traditional teaching of surgery or histology is the best, or clinical diagnosis is the best, is being overtaken by these improvements in imaging with dedicated protocols and standardized structural reporting. Ultrasound is the best with definite role of MRI. So this is where we start, why we should learn imaging. Now, imaging in endometriosis has got roles. With respect to diagnostic, it diagnoses for a subset of people, validating their clinical symptoms. It assesses the severity. It visualizes the anatomical areas which are not visible surgically, like the depth of the pouch of Douglas, which is difficult on laparoscopic assessment. It avoids invasive surgical diagnosis. It minimizes the risks associated with diagnosis. It is definitely affordable, available, acceptable, and safe. From a preoperative or a surgical point of view, the role of imaging in endometriosis is to inform the surgeon, properly providing disease mapping so that he has an idea of the anatomy he would have to handle, thereby preparing the appropriate surgical team. They can take targeted informed consent from the patients. They can counsel the patient with respect to estimated amounts of time for surgery. And above all, from a overall understanding point of view, it improves the understanding of the disease, because imaging phenotype reveals you the natural course of the disease pathophysiology of how you see on imaging, and it has the potential to learn about the progression of the disease. So this is the role of imaging in endometriosis. Now coming to the diagnostic strategies or imaging techniques and protocol. As Dr. Bhaskar had rightly mentioned, in imaging, the level of expertise plays a fundamental role in diagnostic performance. As the famous quote says, what the mind doesn't know, the eye cannot see, even if it exists. In this regard, it is prudent to say the spectrum of deep endometriosis existed far before its detection on imaging in recent years. And it is the clinical interaction with retrospective viewing of images and better understanding of the disease process and pelvic anatomy, which allowed for optimization of imaging techniques and development of dedicated meticulous protocols, which guarantees good diagnostic performance in identification and mapping. Now, if you look into the imaging modalities available and their comparative performances, ultrasound has got the greatest advantage of being dynamic, interactive, non-invasive, commonly available, affordable method with minimal risk and discomfort. But inherent to the modality, both machine and beyond machine, ultrasound has got definite limitations with respect to shadowing, significant pelvic anatomy distortion in cases of significant coexisting pathologies, and limited field of view. Beyond machine, it is operator dependent. Knowledge of the disease is crucial to strategize the study, techniques employed. Coming to MRI, the largest or the greatest strength of MRI is it provides you a large field of view, simultaneous multiplanar imaging, allowing you to assess the imaging in a compartmental manner. The second greatest advantage of MRI is its excellent tissue characterization without the need of giving an extraneous contrast, which provides high accuracy and specificity, delineating the pitfalls. Therefore, it is an excellent complementary modality to ultrasound. Disadvantages include patient's anatomical factor, suboptimal images due to bowel peristalsis, fecal residue, redundant sigmoid colon, and extensive distortion precluding individual detailing. So now you have seen there are modalities, there are advantages and disadvantages of both. So as a clinician, you are the correct person who has the idea of the patient's clinical symptoms and choose the imaging modality appropriately. Sometimes integrated imaging modality is needed to get the complete information. So general remarks on imaging. The test performance of any imaging is operator dependent and will increase with increasing level of training, skill, and experience. For example, the latest survey of ISWAG Whitebound Journal paper quotes the recent analysis of combined use of vaginal palpation, TVS, and MRI. They found at least 2 positive tests was the most valid model for diagnosing deep endometriosis with an accuracy of 91.4. So here, what do you understand? A good clinical examination is the most important, and it cannot be refuted. It is the first base stone on which the strategization of the imaging should be done. But if you compare the overall, the environmental impact of the ultrasound versus MRI, ultrasound has got definitely less carbon footprint and MRI has got the highest carbon footprint. So you should always aim or encourage to learn ultrasound because of its highest yield of information with respect to the side effects or the disadvantages. If you look into the protocol point of view, pre-examination, bowel preparation by Dulcolax is advised in cases of constipated or poor bowel motility patients. For MRI, Buscopan to reduce bowel movements, and in cases of rectovaginal septum involvement or vaginal vault, depending on the initial ultrasound assessment, we can give 60 ml of intravaginal ultrasound gel for better delineation of the walls and its surrounding involvement. So if you look into the dedicated protocol for evaluating pelvic endometriosis, the first step is before ultrasound, a good clinical assessment, specific pain sites. Guiding the examination to pain-specific sites will increase the diagnostic yield. The second is a standard ultrasound examination as described by AIUM guidelines, as we saw in the first slide. This includes visualization of the genital organs, the uterus for its size, shape, orientation, periuterine planes, endometrium, myometrium, and the cervix. Going to the adnexa, ovaries, and fallopian tubes. And thirdly, to look at the cul-de-sac to evaluate the bowel posterior to the uterus. Then beyond this, you have to go beyond. We look at the anterior compartment, bladder with vesicouterine pouch. Posteriorly, you go to the pouch of Douglas, vagina, rectovaginal septum, bowel, trace the rectosigmoid. So this is the targeted compartmental evaluation described by IDEA group, evaluating the anterior, middle, and posterior compartment. This constitutes step 2 to 4 of evaluation. Add to that, you do dynamic assessment of posterior pouch of Douglas for sliding sign to assess the adhesion mobility. And then fourth step is to look for any deep endometriotic nodules in anterior and posterior compartment. Optional is tenderness guided site specific sonography. This is an IDEA consensus protocol for evaluating pelvic endometriosis. Now, once you do a study, you will have findings. Once you have findings, you have to communicate it to the clinical surgeon or classify, or then you conclude the report with regard diagnosis, extent of involvement, staging. So for this, you have n number of classifications, which means there is no single accepted classification in endometriosis. As the disease is heterogeneous, so is the classification, so is the language. So you have AAGL classification, you have an ultrasound-based endometriosis staging, then you have a MRI-based staging, then you have a revised ARSM score, EFI deep pelvic endometriosis score. But I feel the latest NCN is more clinically relevant and correlatable across the lab surgeons. So I will be going to explaining with respect to the NCN system. The NCN system can be extrapolated on any imaging modality, both on ultrasound as well as an MRI. Why? Because this NCN classification essentially describes the finding in a compartmental fashion. So you look whether the pelvis is frozen or pan-compartmental involvement is present or no. This is the first step. Second, you go to the pelvis with respect to compartmental assessment. First is the anterior compartment. The structures labeled are the components of the anterior compartment. This is the bladder, this is the ureter, FB, FU. This is the middle compartment structures. You look for the uterus, myometrium for signs of adenomyosis, you look for ovaries, you look for their mobility, look for presence of endometriomas, fallopian tube involvement, any peritoneal pseudocyst. Coming to the posterior compartment, you have caudocranial involvement with respect to caudally to cranially, rectovaginal space, vaginal fornix, retrocervical space, and till the fundus. Now, B is mediolateral. Mediolateral is uterosacral ligaments, cardinal ligaments, pelvic sidewall involvement. And then you go to the rectum to see for bowel nodules and pouch of Douglas for obliteration. So this is NCN system, which reports the findings in a compartmental fashion, which is reproducible. The same things you can see on laparoscopy. So it forms a common language for communication between the imagiologist and the clinicians. So I think this is clinically relevant classification, and we follow this classification. And you can pictorially represent these with a summary of report giving as a code. P is peritoneal, O is ovarian, T is tubal, A is rectovaginal, that is caudocranial involvement, B is mediolateral involvement, that is the uterus, cardinal ligaments, and then pelvic sidewall ligaments. C is rectum. F is far away location with respect to focal adenomyosis of uterus, for bladder, intestine, ureter, and other locations. So this is the score, this with code POT ABCF. So this is the NCN score. So you have done the study using, understood the anatomy, done the study using a proper protocol. Now you have understood the classification. So structured reporting straightforward with NCN score, checklist of critical findings. This definitely improves the clarity and quality and ensures the consistent terminology. So by this, if you give such a report of a patient, definitely it will give you or the surgeon a roadmap for the disease. So the future of deep endometriosis surgery is IDEA consensus or a proper protocol of evaluation, that is the transcompartmental assessment, and then terminology of any abnormality using MUSA criteria or IOTA guidelines or IETA. So common terminology, international guidelines, classify with a score, that is NCN. So standardization, common terminology will yield a clinically relevant report. Now let us look at the clinical case scenarios. This is a known case of endometriosis with Mirena coil in situ, patient on Dynogest, operated in 2019. So let us look at how this patient's anatomy was seen. The probe is in the anterior fornix. We are trying to look at the genital organ middle compartment structures. So you look here, this is the uterine corpus. The normal anatomy is distorted. There are varying sized multiple intramural myomata scattered all across the anterior and posterior walls. The endometrial cavity is showing Mirena in situ. The cavity is distorted. And this is the ureteral tracing. The ureter is traced from the lateral parametrium across the pelvic side wall. This is the ureter bridging under the uterine vessels. And then posterior compartment, probe oriented posteriorly. This is the rectum, extraperitoneal portion of the rectovaginal septum. This is the rectal wall. Now I trace the rectum all along, come here and see the deep endometriotic bowel nodule sitting right across at the level of the torus. And now with this, I would like to see what is its relationship to the adjacent compartment structure. You turn the probe orthogonally, you see there is a bowel nodule. It is adherent to the right ovary. There is right uterosacral abnormality here. So essentially there is residual deep endometriosis in the posterior compartment and the bowel. So this is how you do the study and interpret the findings. So this is deep endometriosis nodule along the rectosigmoid on the right side of the hemipelvis. Now, can you assess the endometriosis on a transabdominal study, that is unmarried female or where PVS is precluded? Can you try? Yes, definitely. Because as I told you, the same anatomical transcompartmental assessment you can see on a transabdominal survey too. This is the anterior compartment, urinary bladder. These are the ureteric insertions across the UV junctions. Then this is the start of the middle compartment. You trace the peritoneal reflection. This is the parametrium, the uterus. So you see here, the right ovary is adherent. There is a loculated fluid along the right ovary. This is the left ovary. Probe moved orthogonally. The right ovary is showing a chocolate cyst. And then there is a loculated fluid and adhesion at the level of the rectovaginal septum. So you can have a fair understanding of the anatomical distribution of the findings even on transabdominal scan. Only your mind should be able to see those depending on a good clinical assessment. Coming to MRI, in pelvic endometriosis, it is the hemorrhagic nature of the lesions which is an essential element in their characterization. As we know, pelvic endometriosis is characterized by chronic recurrent episodes of hemorrhage and its sequelae. So the 3-plane T2 weighted images is a workhorse of the female pelvis, which gives you an idea of the global pelvic anatomy distortion. You can see here the torus uterosacral ligaments are all nodular, scirrhous, ill-defined, infiltrative borders with pulled up rectum, medialized uterosacral ligaments. So this is distorted pelvic anatomy. The first imaging picture a person gets is the distorted anatomy, and how beautifully this T2 weighted sequence give you an imaging characterization. Now, the second thing is you can also characterize the ovarian cysts with its signal pattern. The endometriotic cysts show blood products. So they are bright on T1 and T1 fat saturated image. This adds specificity to diagnosis of endometriomas to conventional sequences and avoids pitfalls with its differentials on ultrasound. So definite role of MRI because of this signal characterization features on MRI. So additional features are diffusion with ADC, which picks up solid infiltrative deep endometriotic nodules. Optional sequences are SWI, susceptibility weighted sequences. These have got a great role in picking up very early foci of bleed, not apparent even on T1 and T1 fat sat. So these have got a promising role in picking up peritoneal endometriosis in its earliest form. Like you see the peritoneal reflections of the uterus, you can see these foci of blooming, which are not apparent on any conventional sequences, and it can explain the patient's clinical symptoms of bladder if you put these sequences on the background of patient's clinical symptoms. The hemorrhagic nature of the uterosacral ligament involvement, the foci of the hemorrhagic reflections along the uterine peritoneal reflections. With this, the significance of these we will see on a relevant clinical scenario. Like this patient is a 25-year-old unmarried girl with severe clinical complaints of pain lower abdomen, predominantly during periods, more on the right side, radiating to the right leg. This was the clinical symptom. And a transabdominal ultrasound was unremarkable for any great anatomical distortion. There was a well-circumscribed lesion in the uterine corpus. But because the patient was so symptomatic and we could not establish the clinical to imaging correlation, we thought probably there was some form of an ACM or an ectopic endometrial rest which can explain her pain. So we asked for an MRI in this case because there was a imaging clinical dissociation. There was no correlation. So these findings need MRI evaluation during post-menstrual phase to assess the significance for ACM to pick up blood degradation product. And what did we see on MRI? MRI revealed the well-circumscribed lesion to be myoma. It was like a fibroid. The uterus was retroverted, retroflexed. But what could we see? See the tiny foci of blooming over the ovarian peritoneal reflection on the right side. And you see here, the right uterosacral ligament was significantly blooming. So this was an early deep endometriosis along the uterosacral ligament on the right side, which was not otherwise picked up on an ultrasound. And the role of MRI here to establish the clinical complaints. This patient underwent surgery and is pain-free. So can you see the thickened uterosacral ligament on the right side? So this is peritoneal endometriosis with inflammatory distribution in the right head and neck. So this is the role of imaging or the power of imaging in the setting of a correct clinical assessment. So this was our experience, preoperative mapping and structured reporting of pelvic endometriosis on dynamic ultrasound and its correlation on laparoscopic using Enzian classification, which really proved more than 90% accuracy, sensitivity, and specificity. So our clinical experience, the anatomical distribution of the lesions determines the clinical manifestations. Pelvic endometriosis involves multiple compartments simultaneously with predominant involvement of posterior compartment structures in deep endometriosis, namely the uterosacral ligament, rectovaginal septum, anterior rectal wall, and sigmoid colon. The frequency of endometriotic implants in each of these compartmental localization is as seen here. Anterior compartment involvement was 2 to 8%. Clinical manifestations was dysuria, voiding symptoms, suprapubic pain, and discomfort. If you look into the performance of imaging modality, ultrasound 55, MRI 88. Middle compartment structures, thus the performance of ultrasound and MRI is equal. Posterior compartment, predominant involvement, statistically, most common involvement is posterior compartment. If you look into the performance, both ultrasound and MRI do equally well. So, diagnostic criteria, checklist for endometriomas on ultrasound and MRI, potential mimickers, pearls, sequelae, pitfalls, and variants. So, diagnostic criteria wise, endometriomas follow IOTA terminology. On ultrasound, they can be bilateral, more than unilateral, multilocular or unilocular, avascular cysts with ground glass appearance, and can show peripheral echogenic foci. This is the typical pattern recognition imaging diagnostic criteria of a chocolate cyst on ultrasound. On MRI, they are seen as T1 fats at bright with T2 shading, which represents varying degrees of decrease in T2 bright signal depending on the levels and ages of hemorrhages. Diffusion weighted imaging, not specific for endometriomas. SWI or susceptibility weighted sequences show foci of blooming at the periphery. Now, deep endometriosis, they are solid poorly defined margins, hypoechoic on ultrasound, and T2 hypointense. They have infiltrating retractile regions with low signal T2 and occasional high T1 signal intensity foci. Ectopic endometrium showed diffusion restricted or high signal. This is very important in diagnosing atypical scar endometriosis in abdominal walls, perineum. So the diffusion weighted imaging has got a very good role in picking up deep endometriotic lesions. So diagnostic checklist, tricompartmental evaluation mandatory, look for uterus, fixed, retroflexed, posterior wall asymmetry, ovaries, mobility, endometrioma, bladder, is there any nodule, vagina, is there any nodule, pouch of Douglas obliterated, adhesions described, uterosacral ligaments, are they normal or are you seeing any nodules? For bowel, nodule, size, distance from anus, layers involved and adhesions. And then finally, you should never skip the kidneys and look for proximal hydroureteronephrosis based on the imaging findings in the parametrium and the pelvis. So coming to potential mimickers, pearls and sequelae in endometriomas. The trickiest mimickers in endometrioma is a hemorrhagic cyst, cystic neoplasm, dermoid, PID, but there are pearls of picking up. Endometriomas are T1 fat sat bright signal with T2 shading. Associated findings of hematosalpinx, foci of restricted diffusion. Now, endometriosis being a chronic recurrent inflammatory condition with sequelae, the sequelae include range of findings like kissing ovaries, obliteration of pouch of Douglas, vesico-uterine space, adhesions, ureter involvement, hydrosalpinx. So essentially, the pelvis may have a range of findings depending on the age and duration and the spectrum of the involved components. So coming to pitfalls and variants, the complications of the endometrioma, you can see in form of rupture, infection, malignant transformation, intraluminal invasion into adjacent organs like rectum and bladder, complete bowel obstruction. And then the pitfalls can be, you can miss subtle disease like foci of peritoneal endometriosis, or the case like 25-year-old unmarried girl that we have seen where you had to put specific sequence to pick up those foci of bleed, which are not otherwise apparent on routine ultrasounds and MRI. Undercalling multi-compartment involvement with frozen pelvis and decidualized endometriomas. These are the pitfalls. Coming to variants of endometriosis, abdominal wall endometriosis, perineal endometriosis, ureteral endometriosis, invasive endometriosis of posterior uterine wall and anterior uterine wall, which is foam, that is focal adenomyosis of uterine myometrium, which represents a phenotypic representation of deep endometriosis. Appendiceal endometriosis, diaphragmatic endometriosis. Now coming to the typical appearance of endometrioma, unilocular or multilocular, ground glass, thick-walled, avascular cyst with foci of peripheral echogenic areas. So this is the standard typical pattern recognition feature of chocolate cyst. But the trickiest mimickers here, as we saw here, hemorrhagic cyst. Like in this MRI, the one on the above, this is chocolate cyst. The one below is a hemorrhagic cyst. Hemorrhagic cyst represents a functional cyst, which means there is an event of acute hemorrhage within the follicle or a developing follicle. So it's a one-time event. It is a acute hemorrhage which evolves and resolves, whereas endometrioma is a chronic recurrent bleed. So this will have a timeline appearance of presence, increasing in size, decreasing and disappearance. Signal pattern wise, this is on ultrasound with varying features of blood clot retraction, fluid levels, decreasing size, concaving margins, size decrease, disappearance. So on ultrasound, you can have a timeline interval imaging appearance. On MRI, you can characterize by the pattern, signal pattern. An endometrioma will always have T1 fat sats hyperintense signal, whereas a functional cyst will have a fluid signal, that is T1 bright and T2 bright and T1 fat sat hypointense. So this is how you can differentiate mimicker of endometrioma, that is hemorrhagic cyst. The second is large incidentally detected left ovarian cyst. It was referred for an MRI with a differential of cystadenoma. But look here, this is a thick walled cyst, T2 hyperintense, but it is less than that of an adjacent fluid signal. It has thick wall. but how it lights up on T1 fat sat images. So it is an endometrioma and not a cystadenoma. On susceptibility weighted sequences, you can see the foci of blood degradation products along the wall. So other trickiest mimicker can be sometimes cystadenoma. Third is dermoid cyst. Sometimes these upper row represents endometrioma, T2 bright, T1 bright, T1 fat sat bright. Here, endometriomas look at the similar signal pattern on T2, but when you look into T1, the fat remains bright. On fat suppression sequence, this fat is completely suppressed. So thereby distinguishing fat from blood. So other trickiest mimicker of endometrioma is a dermoid cyst. The fourth trickiest mimicker is sometimes PID with TO abscess. So this is endometrioma. Here you look into the lower row of images. It is T2 bright. T1 it is less. It is not as bright as a blood signal. And then zoom out and look into the perilesional abnormality. It has dirty fat stranding, increased pelvic congestion, vascularity. So this is how you can differentiate PID versus endometrioma. So you have seen the four trickiest mimickers. One is hemorrhagic cyst, second is cystadenoma, third is PID, fourth is dermoid cyst. Coming to fallopian tube, 30% of the women with endometriosis have tubal involvement. The dilated tube is easily recognized on pattern recognition as sausage, tubular, hypointense, thickened structure with varying degrees of fimbrial nature depending on the morphology and the status of the dilated tube. And the distended tube will show, hematosalpinx will show typical signal pattern of blood products on MRI imaging. The presence of hematosalpinx may be the only sign of imaging endometriosis in the pelvis. The second spectrum is the superficial peritoneal implants. The first spectrum we have seen endometrioma, its potential mimickers and pitfalls. The second spectrum is superficial peritoneal implants. Current limitation of imaging to pick up early peritoneal endometriosis. Defined relative to the peritoneal surfaces, which normally are clear, sharp, smooth, marginated. So what I really want everybody to understand is a normal imaging plane should have a clear, sharp, smooth margins. Superficial peritoneal endometriosis are endometrial implants 2 to 5 millimeters, which do not distort the pelvic imaging anatomy much. So here comes the role of SWI sequences in MRI, where it is seen as foci of blooming across the peritoneal reflection. But sometimes there are subtle but definite features on ultrasound, like subtle peritoneal thickening with ill definition, cystic areas that come out of peritoneum, pockets of fluids. So these are the areas where enhanced ultrasound imaging protocols are required based on the patient's clinical history. Still, currently, superficial peritoneal implants are current limitation of imaging to be picked up on imaging. Now look at this 28-year-old female. Here, the clinical history is severe dysmenorrhea. Ultrasound pelvic organs ordered. So here, there were small 10 to 11 mm chocolate cyst on either side with ill-defined periovarian planes and subtle features of peritoneal endometriosis along posterior uterine peritoneal reflection. This was on a transabdominal survey. So we ordered for an MRI for confirmation. So here, these are the ultrasound imaging pictures. So can you see the clarity of the uterine peritoneal reflection all along the anterior body and the fundus? But the posterior margins I'm not able to draw the peritoneal reflections. The ovaries are showing small chocolate cysts, but there is no gross deep endometriosis anywhere. If you look into the MRI, there are no gross identifiable chocolate cysts per se, but look at the tethering, angulated margins. See, these are all adhesions. So when you look and put the susceptibility weighted sequences across the peritoneal reflections, see so many foci of blooming. So this explains the picking up of peritoneal endometriosis and can explain her pain, severe dysmenorrhea. So these findings, when interpreted in a correct clinical scenario, will increase the yield. So coming to the third spectrum, that is the deep endometriosis. First, let us look at why it is important to recognize. Now, when you look into the endometriomas, they are easily recognized structure. It's a soft marker for underlying deep endometriosis. While endometriomas are easier part of the surgery, the deep endometriosis goes unrecognized and is the complicated part of the surgery. Now, what exactly is deep infiltrative endometriosis? They are the solid endometriotic implants more than 5 millimeter deep to the peritoneum. So they have a gradient or the depth of involvement due to the hemorrhagic sequelae and bows and distorts the adjacent anatomical planes. They have classic locations of involvement in pelvis, most commonly epicentered in pouch of Douglas. The second part is, why is it difficult to recognize? Because these anatomical locations are difficult for direct visualization. This is why we understood that anatomy, relooking at anatomy is extremely crucial. Various landmarks are identified corresponding to these folds of peritoneal reflection or ligamentous attachment, like cardinal ligament, uterosacral ligament, broad ligament. All these ligaments have a definite anatomical landmark for identification. So, the imaging pattern is atypical with respect to morphology, seen as nodular and infiltrative pattern with involvement of organs in these regions of these ligamentous attachment. Infiltrative regions of deep endometriosis may have foci of heterogeneous foci or complex internal cysts. So this is why it is difficult to recognize. Now coming to posterior compartment, this is the most frequently involved, more than 90%, with the following regions identified on imaging in decreasing order. The most common involvement is uterosacral or torus utrinus. Then comes rectum and rectosigmoid, rectovaginal septum, pouch of Douglas obliteration. Now, as we saw, the torus utrinus or the uterosacral ligament, the landmark is the internal os of the cervix. Midline is torus and posterolateral is the uterosacral ligament. Now, so you should focus on the identification of torus and uterosacral ligament on a transvaginal assessment. See the clarity of the peritoneal reflection. It is interrupted at the posterior lower corpus and torus. What is the morphology of the abnormality here? It is poorly defined, hypoechoic, with involvement of adjacent structures. So what can it be? It is deep endometriotic nodule. The corresponding MR correlate, this is how deep endometriotic nodules look. Solid, irregular, hypointense, infiltrative margins with foci of bleed, ectopic endometrial bleeds. Then coming to this is a schematic representation. So all along this area, you can trace the involvement of the bowel adhesions and you can look at the correlative laparoscopic images. And rectovaginal septum, normal vagina has got a smooth wall less than 3 millimeter with clear, sharp peritoneal reflection along its superior aspect. Now, what happens in cases of deep endometriotic involvement? Look at this vagina. It is obviously thickened. It is nodular. It is hypoechoic. So this is a vaginal nodule. And see this, it is solid, invasive, hypoechoic, projecting into adjacent fat. So the clarity of this fat is lost. And look at the range of extensive involvement. The entire rectovaginal septum is obliterated. The complete rectum is plastered or completely adherent to the uterus. So these are the range of abnormalities. Now tell me, as an organ, it is difficult to identify, but when your mind knows what the normal anatomy is, it is very easy to pick up these abnormalities. So the range of pouch of Douglas obliteration can be from minimal to gross. So this is the schematic representation of ranges of pouch of Douglas obliteration. One very clear finding, consistent, you will see, is the uterine fundus is pulled posteriorly because of the posterior compartment involvement. This is sickle-shaped morphology of the endometrial cavity or question mark sign or given various names. So this is the ultrasound images and the correlative MRI images. So imaging wise, both perform equally well. Anterior compartment involvement in anterior location is challenging. Here, the clinical history is extremely important. Bladder endometriosis may be classified as primary or secondary. Now here you see the high resolution probe which I've used. Sometimes it is masked in multi-compartment involvement. So, but this patient came with complaints of right-sided pain during micturition during periods. So everybody was reporting as left-sided chocolate cyst, pouch of Douglas obliteration. But when you look into the clinical history of pain right side during micturition, you pick up relook the MR imaging, see the subtle thickening of the bladder wall on the right side. The same correlative linear probe, you can see the deep endometriotic nodule. So round ligament area is characterized better on MRI in its intrapelvic portion. Near the labial insertion, ultrasound is equally good. So multi-compartment involvement, because of the multifocal nature of the disease, sometimes the foci of endometriosis are simultaneously observed at different sites. So this is the role of MRI, because multi-compartment direct assessment is possible. So adhesions, direct assessment of indirect signs, tethering of pelvic structures, and loss of corresponding cleavage planes without appreciable nodular lesions. This is the definition of adhesions on imaging. So the range is first distorted pelvic anatomy. Now, how do you define or further characterize distorted pelvic anatomy? It can be in the form of fixed anteverted or retroverted uterus, medial or posterior retraction of the ovaries, that is kissing ovaries, fixation of the ovaries to ipsilateral ovarian fossa, retraction of the bowel towards the DIE lesion, elevation of the vaginal fornix, absence of sliding signs, loculated fluid collections, hydrosalpinx, fluid in pelvis in atypical non-dependent regions rather than cul-de-sac may be another indirect signs of adhesions. So these are all host of signs of indirect signs of adhesions. So as you see, loculated peritoneal fluid, tethering of the structures, bowing of the uterine cavity, the normal pelvic planes are completely distorted. So diagnostic performance of TVS and MRI on pelvic DE mapping, anterior compartment, both fare well, posterior compartment, both fare well, lateral compartment, it is MRI takes over. So if you look into the diagnostic performance of TVS, MRI and laparoscopy in DIE mapping, this is our clinical experience. Imaging performs very well. So there is no role of direct diagnosis by laparoscopy. So it's a big no. Imaging should be incorporated in the diagnosis of pelvic endometriosis. Now coming to special imaging scenarios in pelvic endometriosis, that is fibroids and adenomyosis, focal adenomyosis of outer myometrium, that is foam, variant of deep infiltrative endometriosis, complex atypical anatomical involvement, Mullerian abnormality, endometriosis in pregnancy. So these are all special imaging scenarios in pelvic endometriosis. Now coming to foam. What is foam? Chaperon et al. First described this as transserosal invasive process, that is outside to in pathology. If you look at the uterus, it has got structural components of central endometrial cavity bordered by junctional zone, which represents inner myometrium. Then this is myometrium, outer serosa. Now, if you look into the abnormality here, there is a myometrial abnormality. Second, if you want to characterize it further, it is transserosal in nature and not a junctional zone epicentered lesion. So it's a transserosal myometrial mass with varying depths of innervation into the inner myometrium. So this represents a phenotypic manifestation of deep endometriosis and not intrinsic adenomyosis. See how it differs from intrinsic adenomyosis. Intrinsic adenomyosis, the pathology is inside out. Symmetric or asymmetric globular enlarged uterus. Uterine planes are very clear. Serosa is clear. Here, serosa is irregular. Pathology of the myometrial mass is epicentered from serosa to in. Here it is from junctional zone to out. So this is how foam differs from intrinsic adenomyosis. So here another case scenario, DIE mistaken as adenomyosis. Foam where it can be seen as transserosal myometrial mass with adhesion of the ovary to the uterine serosa. So it is not an intrinsic adenomyosis, but it is a foam, focal adenomyosis of outer myometrium. Similarly, along the right cornual reflection. So complex atypical involvement here, the patient underwent hysterectomy. Patient was interpreted, the findings were interpreted as peritoneal inclusion cyst, but the patient had severe pain, right-sided pain post-hysterectomy. So what do we see here? The uterus is showing peritoneal inclusion cyst. Telltale signs of residual endometriosis was seen in the form of subtle bowel thickening, anterior serosal thickening here, And then this was the ovary which was left behind. Then you could see some solid area with an hypoechoic margin. When you did an MRI here, this is a deep endometriotic area, residual which was left, along which there was a peritoneal inclusion cyst. So complex atypical involvement where the role of MRI stands over to ultrasound. So here, this is another case, Mullerian abnormalities, 15-year-old girl, severe dysmenorrhea, right adnexal cyst on transabdominal ultrasound. It was interpreted as endometrioma. Signal-wise, it is blood signal, T1 fat sat bright, T2 shading. But look into the uterine morphology. It is a unicornuate uterus. It is flushed to the uterine corpus. So and the right ovary is pushed anteriorly and seen separately. So this is a rudimentary, obstructed, canalized, non-communicating uterine horn. So the other spectrum is decidualized endometrioma, where in pregnancy, it represents multiple areas of solid papillary projection mistaken as a neoplastic nature. But you have MRI to help you, or clinically following it up with features of background endometriosis. That is the second way. Now, how does decidualized endometriomas look on imaging? They are cysts with solid papillary projections. So this warrants its categorization into neoplastic morphology on ultrasound. But how do you differentiate it from a true neoplastic nature? These represent solid hypoechoic areas on ultrasound actually represents the stromal decidualized process under the influence of progesterone, and they show the same signal pattern of that of placenta. So if you look, the background signal of the endometrioma is showing profound T2 shading, T1 bright, and T1 fat sat. So this is a background endometrioma on which the solid nodules present the signal pattern that of a trophoblastic tissue or a placenta. So this is how decidualized endometriomas can be picked up confidently and can be monitored conservatively. So locations which are better assessed on imaging than lab, like this is the depth of the rectovaginal septum involvement, which could not be seen on imaging if you would not have preempted this. So this is the strength of imaging beyond laparoscopy. Now coming to endometriosis of abdominal wall and pelvic scars, scar endometriosis may be confined to superficial layers of abdomen or pelvic wall. Endometriosis of the vault in post-hysterectomy setting at the uterine LSCS scar, or sometimes episiotomy scars too. So this is how abdominal wall endometrioma looks. Solid, hypo-intense, infiltrative margins at varying levels of the abdominal wall cross-section. It can be seen in a subcutaneous fat layer. It can be seen intramuscular, but it will show typical features of T1 bright, diffusion, restricted focus, clinically obviously severe pain. So this is vault endometrioma. This is the post-hysterectomy vaginal wall here. The vault is showing, this was interpreted as a Nabothian cyst in the cervix, but look at the MRI correlate. And this is along the LSCS scar. So now you have seen the entire spectrum of endometriosis and the structured protocol, reporting, classification, NCN score. Now, what is the surgical implications of the imaging findings? Surgery for endometriosis has got outcomes and risks and complications. Definitely, there is a tight balance between a good outcome versus risk and complications. And preoperative imaging can definitely provide you a roadmap for surgery for endometriosis, which can aid in improving the outcomes and reducing the risks and complications. With this, I would like to end the talk. So, final slide would be what the referring physician needs to know regarding the imaging. This is the algorithm. Clinical triage by standard clinical assessment. It is undisputable role in treatment decision making because the clinical features depend on the inflammatory distribution of the lesions, which alert for dedicated assessment protocol. The second step is dedicated ultrasound or imaging protocol for endometriosis. Our first line test is ultrasound with equal accuracy to MRI as a screening tool for diagnosis of endometriomas, adhesions, deep endometriosis in the most common prevalent posterior compartment, It aids for patient triaging and management. When to refer for MRI? Ideal is comprehensive or integrated imaging in these cases. When dedicated TVUS protocol is not feasible, like unmarried, complex obstructive congenital anomalies, pitfalls and potential mimickers on ultrasound for adding specificity, suboptimal evaluation in difficult anatomy or advanced disease, add to ultrasound prior to surgical management, subtle disease to confirm, lateral compartment involvement, multi-compartmental involvement, scar endometriomas in atypical locations or complex anatomy, variants of foam, pregnancy with decidualized endometrioma, or malignancy in endometriosis. So these are niche areas or definite areas where definite role of MRI is there. Now, the last is spot the findings here. So look at this image. This was interpreted as a chocolate cyst and sent. Now, if you look into this image, go back, zoom out, look into the image from a compartmental point of view. Anteriorly, pubic symphysis. This is the bladder. This is the urethra. Anterior compartment is normal. Uterus is pulled up, retroflexed. Trace the margins of the uterine peritoneal reflection. Anteriorly, it is normal, fundus going back. It is within the myometrial confines. Now, this is a cystic variety of adenomyosis epicentered along the posterior myometrium. So with this, I would like to end my talk. Thank you so much.
Thank you so much, Dr. Madhavi, for a wonderful, wonderful lecture. I have written down a few questions, but you have cleared all my doubts. So I think Dr. Leela Vyas madam is with us. Madam, can you unmute yourself? Madam is a senior professor, unit head, IVF consultant, member of research viewer board, SMS Medical College, Jaipur, and she's a senior consultant, Cocoon Hospital, and she's the director of Manita CAC, Rajasthan. Welcome, ma'am.
Yeah.
Madam, would you like to conclude?
Yeah, actually, I very late I joined. Actually, I
No
was
problem.
in some condolence meeting, so that's why unable to join that. But the partly I've heard, really, it's a wonderful, and everything has been cleared because everyone think of that the sonography. By sonography, you can't detect the endometriosis because since long we were studying that endometriosis is only by the laparoscopy. But no, nowadays the good imaging, definitely the role of machine is there, but the behind the machine it's always the brain, which helps. So Adit, you have presented a very, very elaborated way, and you have not left anything. Means partly I've heard only the last part, but everything she has covered. And I don't know that everyone must be agree with me. Nowadays, we are facing the epidemic of endometriosis.
Exactly, ma'am. We are agree with you.
So I don't know why it is going on. Yes, all endocrine disruptors and all, we are talking about these things, that these are the environmental toxins which are going through. But we have to concentrate on this disease very importantly because it's not only that fertility is affected or that the pain and the suffering, definitely, which is more and more even, and it affects every age group. And since from adolescent to our reproductive age group and even on the late ages. So really, it's a wonderful lecture, and that this knowledge should be spreaded all over our country. And all our youngsters, those who are so much of in that, whether they are going for the surgery and all, they should have a good imaging, then only land for the surgery. And then they take decision. So thank you very much for inviting me. That's really.
Thank you so much. And Madam is contesting as a President Foxy 2017. So, ma'am, all the best for you.
Yeah, thanks. Thank you very much. And I think now that it has become one of the major agents, we are struggling with anemia and all everything. But I think someone has to come forward and talk about the endometriosis every day and every part of in all our conferences and all this.
Exactly.
So we can help our patients. Basically, we just help in their sufferings. That is more of that. And Dr. Madhvi, that very nicely presented.
Thank you. Thank you. Thank you so much.
Dr. Madhvi, we
Yes.
have usually problems, youngsters, unmarried girls. So endometriosis usually mimic the tuberculosis sometimes.
Yes.
How you want to address on that? And second question is how you trace ureter on transvaginal scan, if you can.
Yeah. Uh, like if you have to ask me how do you differentiate PID or a tubercular nature versus endometriosis, certain findings like the first of all, the contents of the cyst. Endometrioma, it is blood signal. T1 fat sat bright. There are adhesions, but the pelvic fat planes are not grossly distorted. Whereas in PID, the entire fat planes are first grossly lost. The cyst contents will be showing abscess signal. It will be T2 dirty signal. It will not be T1 fat sat bright like that of a blood.
Yeah, madam,
I
on
should-
sound, I'm just saying, we suspect sometimes endometrioma, but it turn out to be a
Yeah, that is the most common scenario.
So can you,
The brightness of the surrounding echogenic fat in the pelvic peritoneum with
right.
increased tenderness. That is one of the findings of PID rather than endometriosis. Second, endometriosis, pouch of Douglas, the torus uterosacral area is very commonly involved. Whereas in PID, fundus and tubovarian location, the upper part of the pelvis is obliterated. Sparing of POD, that is another crux which you can differentiate. And third, clinical history. Fourth, you take resort of MRI. Fifth, by putting in a needle and aspirate.
Right. And my second question, how you trace ureter, both the side, how we should approach to see on transvaginal? Dr. Madhavi, your network is, I think, unstable. We're not able to hear you. Preeti ma'am, are you able to hear?
Yes, yes.
Dr. Madhavi? I think
I think I frozen. Her
network
screen
issues.
frozen. Yeah, some network.
I think I think she's rejoining. Meanwhile, I would take this opportunity to give a vote of thanks. I really now would like to thank today's distinguished guests, Dr. Shyam Desai sir and Dr. Bhaskar Pal sir, for their wonderful words of wisdom. My deepest sense of appreciation to Dr. Bela Bhatt madam and Dr. Priya Bhave madam for giving me this opportunity and always guide me and support me. I highly appreciate of today's esteemed chairperson, Dr. Leela Vyas madam, Dr. Preeti Sharma madam, and Dr. Abha Jain madam for their valuable inputs. Special thanks to our eminent speaker, Dr. Madhvi Nori, for their lucid talk and sharing her expertise and experience with all of us and clearing all our doubts. I want to express my gratitude to all our delegates who joined us today and make this webinar interactive. So I think we would close now. Thank you so
Yes,
much.
thank you.
Everyone.
Thank you, Shalini. It was really lovely to be with you all.
Thank you.
It was so informative.
Right.
Yeah.
I think nowadays it's spreading like endometriosis.
Yes. It's such a common thing that we have to keep endometriosis as number one diagnosis in our mind whenever we are seeing a patient. Right?
Exactly.
Previously, it was true that we used to see many tuberculosis patients or other things, but nowadays endometriosis comes first. And then it was believed to be a disease of not Indians, but was supposed to be among the English people initially. But now the incidence is more in India. It's rising.
Exactly.
Yeah. So thank you so much.
Thank you so
Yeah.
much for joining.
Yeah.
Thank you.
Thank you.
Mr. Himanshu.